Hey everybody, we have a medium difficulty cardiology question. It can be easy for some of you. So this question describes a 21-year-old male who presents with features of malaise, weight loss, joint pain, and night sweats. On examination, he is feverish, tachycardic, but his blood pressure is normal, and we have petechial hemorrhages in his conjunctiva and buccal membranes. We also have splinter hemorrhages in his nails, Osler nodes as well. These are the tender red nodules on his palms. Those are Osler nodes. An auscultation of his chest reveals a hollow systolic murmur at the lower left sternal border. So far we have features that are very consistent with subacute bacterial endocarditis. Okay, it's not a very difficult diagnosis at this point, but what I want to point out is that they tell you that his echocardiography is abnormal, but it reveals no valvular lesions. Okay, so all the valves are normal. So why do we have this murmur? And a hollow systolic murmur at the lower left sternal border is highly consistent with a ventricular septal defect. So this question highlights the fact that if you have an untreated small ventricular septal defect, that puts you at an increased risk of developing bacterial endocarditis. In fact, some studies show that you're 20 times more likely to develop infective endocarditis if you have a VSD that is untreated. And even if you haven't treated VSD, you're still 2 to 3 times more likely to develop infective endocarditis. So it's a pretty significant risk, and this is something that you should be familiar with. So there's a lot to discuss about infective endocarditis, but I don't want to talk about it because I don't want to make it the focus in this video, because I want to talk about the answer choices, okay? So it's asking about, if we perform catheterization on this patient, what would we find? So answer choice A says increased systemic vascular resistance. This is not correct, because with increased systemic vascular resistance, you would have elevated blood pressure. His blood pressure currently is normal because pressure is directly proportional to the systemic vascular resistance. So the higher the resistance, the higher your blood pressure will be, but we have a normal pressure in this case. So we would expect normal systemic vascular resistance, or if any, there will be a decrease in systemic vascular resistance. So I'm saying decrease because if the patient goes on to become septic and develop septic shock, we would have widespread peripheral vasodilation, and resistance is inversely proportionate to the diameter of the blood vessel. So if you have vasodilation, you would increase the diameter of blood vessels, and that would decrease your systemic vascular resistance, leading to hypotension and shock. This is one of the mechanisms why patients with sepsis go on to become hypotensive. So answer choice A is wrong. We would expect to be normal or even decreased. Answer choice B says a pressure gradient between the right atrium and right ventricle. So a pressure gradient refers classically to stenotic valvular lesions. So for example, if you have the left ventricle that during systole it contracts and the aortic valve opens, it allows communication between the left ventricular cavity and the lumen of the aorta. And because of this communication, the pressure of the left ventricle and the aorta would equalize. And that's why the left ventricular systolic pressure is equal to the systolic pressure of the aorta, because the aortic valve opens and it equalizes the pressure on the cavities that are present on either side of the valve. But if you have, say, aortic stenosis, then the left ventricle would have to pump harder, generating more pressure in order for it to open the valve, but the valve would not really open that much. So it would not be able to equalize the pressure on the cavities that are present on either side of the valve. So you would generate a pressure, say, of about 160 millimeters of mercury in the left ventricle during systole, but the systolic pressure of the aorta would be, say, 120. So there's a pressure gradient between them about 40 millimeters of mercury. So pressure gradients usually refer to stenotic valvular lesions. And a pressure gradient between the right atrium and right ventricle refers to tricuspid stenosis. So if you have, because of tricuspid stenosis, the tricuspid valve does not open, you won't be able to equalize the pressure between the right atrium and right ventricle. So the right atrial pressure has to generate more pressure in order to open the valve. So the pressure within the right atrium increases, but it will not be equal to the pressure within the right ventricle. Therefore, there will be a pressure gradient between the right atrium and right ventricle. However, they clearly tell you that the echocardiography reveals no valvular lesions. The valves are normal. So answer choice B is also incorrect. Answer choice C and D are both incorrect, because pulmonary capillary wedge pressure is the pressure within the pulmonary capillaries, and these are continuous with the pulmonary vein and the pulmonary vein is continuous with the left atrium. So pulmonary capillary wedge pressure is equal to the left atrial pressure. And as we've already established, when a valve opens, in this case it's the mitral valve, then the pressure between the two cavities on either side of the valve would equalize. And so that would mean that the pressure within the left atrium is equal to the left ventricular diastolic pressure, because during diastole the mitral valve opens and equalize the pressure between the left atrium and the left ventricle. So left atrial pressure in the absence of valvular lesions is also equal to left ventricular and diastolic pressure, or also referred to as filling pressure, because during diastole that's when you fill the ventricle. So why would you have elevated pulmonary capillary wedge pressure or elevated left ventricular filling pressure or diastolic pressure? So you can see this in cases of left ventricular dysfunction. If you have left ventricular failure, then the left ventricle will not be able to pump all that blood to the aorta, and so all that blood will accumulate within the left ventricle, and that's going to accumulate and exert a lot of pressure within the left ventricle during diastole. And this is in fact one of the hallmarks of heart failure. One of the hallmarks of heart failure is elevated filling pressures, because the ventricle cannot pump all that blood, so it's going to accumulate and it causes a lot of pressure. And in the absence of any valvular lesions, the left ventricular diastolic pressure would be equal to left atrial pressure, so that also will be elevated, and left atrial pressure equal to the pulmonary capillary wedge pressure, so that also will be elevated. So if we have left ventricular dysfunction or failure, then we would have elevated pulmonary capillary pressure. However, they tell you that the echocardiography reveals an ejection fraction of 67%. This is normal, okay? So an ejection fraction of 50 or more is normal. 40 to 50 would be borderline, less than 50 is abnormal. So we don't have evidence of heart failure with reduced ejection fraction because the ejection fraction is normal. And you might think, okay, could this be heart failure with preserved ejection fraction? Well, we don't have any symptoms of heart failure, left-sided heart failure like dyspnea. His chest X-ray is normal, so we don't have any features of pulmonary edema or hypertrophy. And also, the ECG shows only first-degree AV block, as evidenced by a PR interval that is prolonged. And ECGs are very good at detecting hypertrophic changes of the heart, so it's very sensitive. So we don't have anything that tells us this could be left ventricular dysfunction. Now, another way you would have elevated pulmonary capillary wedge pressure in the setting of normal left ventricular filling pressure is if you have mitral stenosis. As we already established, there would be a pressure gradient between the left atrium and the left ventricle, because those are the cavities on either side of the valve. If you have mitral stenosis, the left atrium has to generate more pressure in order for it to pump against a stenotic valve. But because the valve is stenotic and there's only a tiny hole, it would not be able to equalize the pressure between the left atrium and left ventricular diastolic pressure. So left atrial pressure will be elevated. You might have a normal left ventricular filling pressure, but left atrial pressure will be elevated. Therefore, it backs up to the pulmonary circulation, increasing pulmonary capillary wedge pressure. But again, they tell you that the echocardiography reveals no valvular lesions, so his heart valves are normal. So answer choices C and D are both wrong. The correct answer in this case is answer choice E. Increased oxygen content within the blood within the right ventricle. So because this patient has a VSD, we want to know in VSDs the direction of the shunt and the magnitude of the shunt. So how much his blood is being shunted. And this depends on the size of the shunt. So we have a small shunt. If we have a small shunt, as in this case, then this is called a restrictive type because the VSD is small, and because of that, each ventricle will retain its normal pressure. So the left ventricle will have a normal pressure and right ventricle will have a normal pressure. And as you know, normally the left ventricular pressure is higher than the right ventricular pressure. And blood likes to flow from areas of high pressure to areas of low pressure. So we would have a left to right shunt. Blood will be shunted from the left ventricle to the right ventricle. But the magnitude of the shunt is limited by the size of the defect. The small VSD will only allow minimal amount of blood to be shunted from the left ventricle to the right ventricle, so it doesn't cause any increase in pulmonary blood flow. However, because it is passing through a tiny hole, this would generate more turbulent flow, causing the murmur, and this would cause damage to the endocardium, making you more susceptible to develop an effective endocarditis, as in this case. So because the blood within the left ventricle is oxygenated and the blood with the right ventricle is deoxygenated, because of that left to right shunting, oxygenated blood will mix with deoxygenated blood within the right ventricle, increasing its oxygen content. That's why we can see increased oxygen content within the blood of the right ventricle. That's why this is the correct answer. Now, sometimes the left ventricle might directly eject its blood directly into the pulmonary artery without it passing in the right ventricle. And in that scenario, this phenomenon is referred to as streaming. Okay, so streaming is when the left ventricle and it ejects blood directly into the pulmonary artery. And in that case, the oxygen content within the blood of the right ventricle, it might be normal and or slightly elevated, but the oxygen content within the pulmonary artery is elevated because that's the site that is receiving oxygenated blood. You probably won't be asked about it. I'm just telling you because it's a cool fact. Okay, so what if we have a large VSD? Okay, what determines the direction and the magnitude of the shunt? If you have a large VSD, this is referred to as a non-restrictive type, meaning that both ventricles, the pressure between them will be equalized. So the pressure within the left ventricle is the same as the pressure within the right ventricle because of the hole that is so big, it's almost as if they're one big ventricle. And in that case, the pressure gradient between them, it's not going to determine the size of the direction of the shunt, but what determines that is the systemic vascular resistance, that is the resistance within the aorta, or the pulmonary vascular resistance, the resistance in the pulmonary vasculature. So, and the direction of the shunt will be towards whichever is lower, whichever resistance that is lower. So when you're born, your pulmonary vascular resistance is high. It's not as high as the systemic vascular resistance, but it's still high. So the blood will be shunted, if you have a large VSD, from the left ventricle towards the right ventricle, because that's the side of the lower resistance. However, because of that minimal difference in the resistances, there will be minimal amount of blood that is being shunted. So the magnitude of shunt is minimal when you're born. So you don't really have any symptoms of VSD. However, as the days go by and weeks go by, your pulmonary vascular resistance drops. This is also a normal process. But if you have a VSD, that will increase the magnitude of the difference in the resistances between the two circulations, and that thus will increase the amount of blood that is being shunted from the left ventricle towards the right ventricle. And because of increased blood flow within the pulmonary circulation, it's going to receive blood from the right ventricle, receiving blood from the left ventricle. That shearing force against the blood vessels will cause the endothelium to release substances like endothelin, thromboxane A2, which causes platelet aggregation, vasoconstriction, and because of that, the pulmonary vascular resistance will start to rise. So the diameter of pulmonary blood vessels will decrease, therefore increasing the resistance. And so the pulmonary vascular resistance will continue to rise to the point where it gets close to the systemic vascular resistance, and that will minimize the amount of shunting, okay? Because that minimizes the difference between the pulmonary and systemic vascular resistances, reducing the amount of blood that is being shunted, and so the patient gets better. His symptoms improve. Now, if the symptoms of a patient with VSD start improving, this could be because the VSD is spontaneously closing, although this is very unusual beyond the age of 4, and after that age, it is most likely indicating that the pulmonary vascular resistance is increasing. So this is a warning sign, because that pulmonary vascular resistance will continue to rise to a point that it becomes higher than the systemic vascular resistance, and the shunt will be towards the left side because that is the side with the lower resistance. So you're going to have right to left shunting, right? You're going to have blood flowing from the right ventricle towards the left ventricle. And because the right ventricle contains deoxygenated blood, then deoxygenated blood will be flowing to the left ventricle, and the left ventricle will pump deoxygenated blood to the circulation, so you develop cyanosis, hypoxia, and hypoxia will stimulate erythropoietin release, and erythropoietin will cause polycythemia, and that's when you develop Eisenmenger syndrome. And in this case, it's usually inoperable, and the prognosis is very poor. So that's all I wanted to talk about in this case. I wanted to point out that VSDs, small untreated VSDs, put you at an increased risk of developing infective endocarditis. You're 20 times more likely to develop infective endocarditis if you have a VSD than if you don't. If you want to see more of these videos, you can give this video a like, subscribe to the channel, and thanks for watching.